Alex.
Hi, Antonella. Nice to see you.
Good to see you too. I'm excited we're going to do things a little bit differently today, and that we're actually not looking at a study, but we're going to be looking at guidelines. So these guidelines are an update to 2018 guidelines, correct?
That's right. It's my one true love. We're talking about lipids and cholesterol today.
Yes. So this will a little bit also just be me probing you more for questions because this is definitely your area of expertise. But maybe just orient us to who puts out these guidelines, maybe also like what guidelines do. Like, I think we all have a general understanding of what a guideline is, but sort of in the context of medicine, like why would we get so excited that there's new updated guidelines in the first place?
Well, excited. I think not everyone gets super excited, I guess, but we get
In
excited.
certain crowds.
Yes, in certain crowds, exactly. So guidelines are put out by a variety of major organizations related to health, and they're sort of, for lack of a better term, a collection of the best data, and a team gets together and they look at, what's happened in the research since the last guidelines were released a number of years ago, usually. And they collectively decide what the through line is and what represents the best state of understanding on assessment and treatment and all the things that have to do with a particular condition or scenario. So you see this in all areas. Cardiovascular medicine has myriad number of guidelines, including the lipid guidelines that we're going to talk about today. There's guidelines on osteoporosis, guidelines on mental health guidelines or gastroenterology guidelines, and in different areas within each of those umbrellas. And different organizations are involved and they come out at, different frequencies from different organizations. So if I'm more specific about the lipid guidelines, the three major international organizations that look at lipid guidelines are the Canadian Cardiovascular Society, which is in my turf, the AHA-ACC Multi-Society Guidelines, which is in the US, so the ACC, the American College of Cardiology, and the American Heart Association, as well as a number of other organizations that come together to create those guidelines. And then the European Society of Cardiology and Atherosclerotic Society also do their guidelines.
All of right off the tongue.
Right. And they do guidelines, heart failure, like
Yes, high
so
blood
many
pressure,
guidelines.
yeah.
Exactly. But these are the lipid guidelines. And until last year, Canada had the most recent guidelines. So Canadian guidelines came out in 2021, and until 2025, basically, they were the newcomer, all the recent information. So I especially would refer to those because they were the ones not only that allowed me to speak the same language as all the other healthcare providers and be able to connect on the assessment recommendations, but it was the most recent. And so it felt really good to be able to say, okay, like we're paying attention to this now, even though that's not in the US guidelines or the European guidelines, because the bulk of the evidence today is now saying this is important. But since 2021, of course, more research, greater understanding, lessons learned, and so on. European update to their guidelines came out last year. And then just a few weeks ago, so we're in March 2026 right now, or sorry, we're April 1st, 2026. But a few weeks ago in March, the new US guidelines came out. So the ACC, AHA, Multi-Society guidelines came out. So that makes them the most recent guidelines. And so I think it's a great document and really helpful to understand how best to support our patients, right? Because it runs the gamut of every type of patient, what we're looking for, what thresholds about cholesterol we have to worry about, how to best treat in all the different iterations. Yeah, where things stand in relation to cholesterol and how to best support people.
Totally. So this is a long document, so we're not going to go through it line by line. It's also building on previous documents. So, right, we're not starting from scratch. So some things are the same. Some things, of course, are updated. The list of things that are new in this is actually extensive. So we're not even going to go through it line by line because that would be so boring. Like only Alex and I would find that exciting. And probably another few souls out there to get like that granular. But what we talked about is that like the big idea here is that there's this emphasis on, I think, like stepping outside the stereotype of like a cardiac risk patient or like a high cholesterol risk patient. And so that there's now much clearer mechanisms to help identify people at earlier risk who may not look like we traditionally think they should look or have looked in the past. And so that way that we're treating earlier and really having this like more effective prevention or primary prevention focus. Sort of broke that down, but even before we get there, I think, Alex, it's really important for you to speak of this idea of like treating earlier and longer in your cholesterol, not your cholesterol years idea, but I know an idea that you really advocate for,
Yeah.
because I think that's going to set up our understanding of like why this is a shift and why that's so important. Because I think people often think of cholesterol, especially like from a public health, being like proactive about your own health. I think we often think about it like older, later in life, just if it's high, then I need to do something about it. And the guidelines are really going to push against this, but we sort of need to understand this idea of treating earlier and longer in cholesterol years. I think for anything else we're ever going to talk about from here on out to make sense. So if you want to walk through this first.
Yes, I would love to, because yes, I feel pretty passionate about this concept, which
Yes.
I did not make up. And this has been something that's been understood for quite a long time, but has not trickled down into the guidelines or sort of general practice. And so sometimes it feels like swimming upstream when I'm talking about this with patients, because it is a really important concept. It's the idea that with cholesterol as the like necessary ingredient for development of plaque, and that plaque formation increases the risk of cardiovascular disease over time, that this process takes many decades really to come to fruition in most cases. And the longer we're exposed to elevations in cholesterol, the more opportunity we have to develop plaque, which increases the risk over time, even if there's a long runway to that. Really, it's the idea that if your cholesterol is lowish and then it comes up suddenly in our later years, that would be, I'm going to say, quote unquote, better than if it was sort of elevated all along and is then exactly the same number as someone at that point. The numbers may be the same, but the exposure over time has been different. And the opportunity for the cholesterol to develop into plaque and cause problems is greater. So the cliche sort of example I give is sort of aligning it to the idea of smoking pack years, right? So if two people are sitting in front of me, they both say they're smoking a pack of cigarettes a day, and I ask, oh, okay, well, let's work to change that. But then I ask more details, and one person says, oh, I've been smoking a pack of cigarettes a day for 40 years. And the other person says, oh, I just took it up last week because it seemed cool or something. Obviously, I think we can all be really clear that we're more concerned about the person who's been smoking a pack of cigarettes for 40 years, even though the first answer was they're both smoking a pack of cigarettes a day. And so the concept with cholesterol is not dissimilar, which is that the longer you're exposed to it, the more damage it can cause. And that there was no mechanism for that concept to be captured in most guidelines. And there's a variety of reasons for that, but not the least of which is if you're looking at short risk assessments, right? So if you're only looking at a 10-year risk window, which will then sort of just dictate how worried we are and what we're going to do in relation to your cholesterol, if people are younger, or, and this is traditionally the big argument I have, typically women are going to be considered at lower risk because of things, right? So a 30-year-old, even if their cholesterol is elevated, isn't going to be a particularly high risk of heart disease because it takes a while to develop, even if their cholesterol is elevated. Fast forward with that person to 60, they're at greater risk, even if the number of cholesterol is the same, because they've had 30 years of that number to cause problems. But if you look at them at 30 and you go, what's your 10-year risk? Between the ages of 30 and 40, they're not likely to be at great risk. Women see a risk to their heart disease go up postmenopausally. There's a relationship with estrogen there. But what that typically looks like is that group, that population is considered low risk until their 60s or beyond, regardless of anything else, because it's got this protective piece. So we've got these populations, and I'm using those two particularly because that's kind of what the new guidelines are better at recognizing. These people who aren't obviously considered at risk of heart disease, either because they're premenopausal or because they're younger. And we've kind of disrespected. We haven't given the cholesterol, especially if it's elevated at those points in time, the respect it deserves, even though it's building and creating potential problems over time. Kind of just kept answering your question there, but
No, that's good.
that's the cholesterol years concept,
That is the
and
cholesterol years.
yes,
Yeah.
and why it can matter in patient populations that are not being evaluated as higher risk.
Yeah, and I think, like, in practice, I mean, we don't have time to really get into all of those myths, but I think so many women will go in, at 40, 45, or maybe on the cusp of being postmenopausal and have their cholesterol checked and it might be slightly elevated. And their practitioner will maybe say, like, oh, it's not too high. We'll just keep an eye on it. And I think have like very strong feelings that, like, one, this is such a opportunity to educate and prevent. And that, I think, should be the choice given to the patient so that they really understand what's going on from a cardiovascular risk perspective. And so I think these guidelines are really giving us ample instruction to start to have those conversations, right? This is what it looks like to be this age at this cholesterol. This is what 10-year risk or 30-year risk might look like. This is what it looks like if we lower it, right? These are other investigations we can do to conceptualize this number for you. And so one of the tools that was highlighted in these guidelines is the prevent calculator. And so I know that you are a big fan, but if you'll tell us a little bit more about this calculator and sort of what new things you think it gives us and why it's positive iteration of the calculators we used before.
Yeah, so the calculators are an integral part of kind of establishing how we look at someone's cholesterol level. And different calculators exist. They started as sort of these 10-year risk calculators. So you answer questions about age and sex and whether you're diabetic or not, and whether you're a smoker or not, what your blood pressure is, sort of at the most basic level. Those are the foundational question, which kind of is highlighted by the Framingham score, which is what we still use in Canada. That calculator, you put that information in and it spits out a number, which then dictates whether you're low risk of cardiovascular disease in the next 10 years, intermediate risk of cardiovascular disease in the next 10 years, or high risk of a cardiovascular event in the next 10 years. And there's numbers to go along with that, but that's kind of what happens. And then depending on if you're in the low, intermediate, or high risk category, we say we're more or less worried for you, and we're going to be more or less aggressive about managing your cholesterol level depending on what it looks like. That's at its most basic level. In recent years, there's been a real move to a longer expanse of time, right? So instead of the 10-year scenario, which we could only start using in people who were 40 years old, now we're looking at either lifetime risk, or with this most recent prevent calculator, 30-year risk, which is not quite lifetime, but meant to approximate the same thing. Framingham score is what we use, or what the Canadian Cardiovascular Society recommends and advocates for in Canada. In the US, it used to be what's called the pooled cohort equations, or PCE, which is what was underpinning the ASCVD plus calculator plus, or plus calculator, which is what's been in use for a number of years until just recently. And then in Europe, they have something called Score 2. And there's different iterations of that, which is like country specific. So some countries are at higher risk of cardiovascular disease, and that gets baked into the calculator. And there's like different iterations on that. One of the conversations has been certainly in relation to Framingham score, and then more recently comparing this pooled cohort equation, or the ASCVD plus, and the newest prevent, is that the prevent really looks at a contemporary population. It drew information from a huge number of people, like today. And so it's not historical data. It's more diverse. It's wider ranging. It's really a greater snapshot of, like, if you're putting anyone through the calculator, you're more likely to capture what risk really means for people. If I look at the Framingham risk score, like that calculator was the OG calculator, was created decades ago, and the information used to validate it was a population from many, many decades ago, right?
Yeah.
And it is not particularly diverse. and is not really representative of what cardiovascular risk and environment looks like today.
Mhm.
Something like the Prevent calculator, certainly in contrast to Framingham, and to some degree in contrast to the PCE that came before it, includes more things. Now, some of those things are baked in, but some of them are optional. So one of the really interesting things that was added was a zip code
Mm.
piece, right? And so that's meant to pick up some socioeconomic risk factors. So depending on, because there's well-established scenarios where location, and there's lots of different reasons for that, but we see pockets of increased cardiovascular risk. And to be able to capture that, those aspects of demographics, which have to do with social determinants of health and things that are outside of people's control, can be pulled in so that they're better evaluated, so that they're, if someone's at greater risk, that they're actually identified as being at greater risk compared to a peer who may have similar other factors, but not have to deal with particular like aspects of systemic bias or food deserts or whatever it might be, right? So the there's so many, I think, pretty wonderful things about the new Prevent calculator, just starting with a really contemporary population was used to inform the calculator. It's got these extra pieces of information, some of which are optional, but they all fuel a more accurate assessment. And it's got that 30-year component to it, which for the US calculator isn't
Mm.
that much different. Certainly in contrast to our Canadian Framingham is something I appreciate because we don't
Longer
have
term.
that
Yeah,
longer
view.
term. Because absolutely you're going to find people who are considered at low risk in the short term. But if you take their okay values today, but you apply that to a 30-year period of time, all of a sudden they get flagged. And that is so valuable because that's what we see in primary prevention, which means someone doesn't have established heart disease, but we're trying to do best
Avoid it.
by
Yeah.
them over
Mhm.
time, right?
Mhm.
And if you're told everything looks okay, what you hear is everything is awesome
Yeah.
and I don't have to change anything, right? And the fact is people want to know if they're like, well, if I had just known that that could be better and that increases my risk over time and I could just work to change it, I just needed to know it was an issue,
Yeah.
right? And having a 30-year or lifetime calculator allows for that because you can do both and go, okay, well, 10-year looks totally low risk. 30-year tells us a slightly different story. And now the guidelines not only allows for that calculation, but follows through with that to say, if you see a different kind of,
Mm.
low here, not low here, you qualify for a conversation. For a conversation that sounds like gatekeeping that we were
Yeah.
talking sort of before the call, but that identifies someone where active lipid lowering would reduce their risk overall.
Mhm. Mhm.
And we're trying to prevent a problem from happening rather than like waiting until things are like, oh no, we need to change that yesterday. And you have
Yeah.
to try and pull out of the stops or make changes that feel impossible or be on a higher dose of medication that might otherwise have been needed.
Yeah. Okay, so the calculator is something new in these guidelines. Another aspect that is important in the guidelines is that we now have thresholds. We actually have numbers that we could really target. So before there was like a percentage reduction that we would look for. So that's how we would talk about statins to a certain degree. They're going to reduce this number by, 15, 20% to 50%, and we wanted to see a reduction, but there were actual like treatment targets of like, we'd like to get this number below 70 nanograms per deciliter. Sorry, units are not my forte. Milligrams.
Milligrams per deciliter.
Yeah, okay. That is now public. So there you have it. Or, et cetera.
Yeah.
And so having those thresholds, I think, is important now because there's an actual goal in mind, and that objective data can be really, really helpful to calculate like whether someone needs a single medication, whether or not lifestyle might get them that way, or if we need to layer on medications or, do a couple different things that makes things just more concrete and straightforward, I think.
Yeah, just like pragmatic, right? And
Mhm.
and that's helpful for both practitioners and patients, right? Because the number of times where it's like, okay, the guidelines, whatever guidelines have sort of flagged that based on your risk, your low, intermediate, high risk, And based on your LDL cholesterol, typically, active lipid lowering is warranted. Statin medication is, this is what we're going to discuss. And then the percentages would be like, well, we expect or hope that it's going to go down by 50%. It's like, okay, but if you're starting someone, same person, but maybe this is where our cross-border conversation
Yes.
goes a little sideways, right? I'm going to use my millimoles per liter.
Oh,
So
and then we
let's
can make a note
say,
in the description with
right.
the
Yeah.
conversion because
Yeah.
I cannot do that in real time. I
Yeah.
can barely do real math.
I mean, I can kind of guesstimate what that looks like with the milligrams per deciliter, but if two people exactly the same parameters otherwise, and they're both flagged as, we've encouraged a statin, but one of them is at, let's say, 4.3 millimoles per liter, and the other one's at 3.9 millimoles per liter, and we just say like 50% reduction, and one of them's 45 and one of them's 47, the end result could actually look relatively different because there wasn't a specific goal of getting it to like 2.6 millimoles per liter, which is your 100 milligrams per deciliter. I remember that. Right. So if you're starting at like 130 or 150, let's say, or 170 even, and you just say give or take 50%, but it's like it can land anywhere when we have evidence that getting it past a certain point is going to be better, right?
Yeah.
And so I think it just helps to have a target, because otherwise, how do you feel successful?
Yeah, and that the data was really going in that direction, and I think reflected in conversations we were already having. And so then to have that reinforcement through the guidelines, where now there's just this like common standard that this target helps put someone in a lower risk profile versus all of that number, I think just makes for clearer conversations, clearer crosstalk between practitioners, and is most up to date with the evidence. Which
And
that's a nice
especially
spot to be sitting in, I think.
totally. And I think there was like an ebb and flow to that. So there were thresholds and sort of goals in the past, and then the 2018, which is the most prior to 2026, your most recent guidelines. The 2018 guidelines dispensed of those thresholds, and there were thoughts as to that would help with practice, like it would allow for more ease in working with people in lipid lowering. But I think the practice of it disputed that, right?
Yeah.
And so they were like, what? I think
We're
that
bringing them back.
that's right. It didn't work out the way we thought. And so this was definitely a return to,
Yeah.
but in an excellent way, which I also really appreciate, that we can sort of try something thinking it's going to be of benefit, and then recognizing it's not, and then go, well, we learned something, lessons learned, and we're
Yeah,
going to move
let the
forward
just course.
with just something that's going to make more sense.
Yeah.
Yeah.
Okay, and then I think the final sort of big area, sort of like big bucket that's in that, like, how do we take someone who isn't that like typical person we would worry about with high cholesterol, right? So we've got a calculator that's giving us more information. It's projecting out into the future. So we have a much more realistic information around risk today rather than like 10 years, you look good. I don't know
Right.
about the rest of the time period. We've got some thresholds that if we know we were going to need to do some lipid lowering, like our goal. So we've got some goal lines, which is nice, but also this conversation around risk enhancers. So this is, I think, a lot of times in those gray zones, like someone might not actually have high cholesterol, but they maybe have other risk enhancers. So how do we start to talk about that? Or if you have slightly high cholesterol and a risk enhancer, how do we talk about that, right? There's all these like exceptions to the rule. Like it's really easy when someone's cholesterol is 400 and you just know they need treatment. That's pretty straightforward, but people are much more nuanced and complex than that in real life. So this risk enhancer emphasis, I think, is an important part of the equation as well. And there's lots of avenues to sort of gather that information. If you want to give us the highlights, potentially.
Yeah. And I would say this is the area where it ends up being a little loosey-goosey, for lack of a better term. And part of that is because these things have been identified as items that will increase cardiovascular risk for a variety of reasons, but we don't know how to quantify that with total accuracy. So we have identified things that we need to keep in mind, and I really appreciate the breadth of the risk enhancers this time around, in part because it really includes the sort of sex specific things based on kind of reproductive. So, like
Mhm.
scenarios of like in pregnancy, so pregnancy, like preeclampsia or
Yeah.
hypertensive disorders of pregnancy or gestational diabetes. So, things that have increasingly been identified as items that will increase future cardiovascular risk, but haven't been talked about in this context. And so there's a list of things like that, which include inflammatory conditions, HIV, rheumatoid arthritis, a variety of inflammatory conditions, or just the presence of elevations in inflammation, particularly inflammatory marker CRP. So this is really more explicit about CRP, and it says if you measure CRP and it's elevated on two separate occasions, that's going to be considered a legitimate risk enhancer. Things like diabetes, which is sort of in and of itself more than a risk enhancer. It's like this other level. And actually, HIV is now in that category as
Yeah.
well. Elevations in Lp(a), which has a much more prominent place in these guidelines compared to prior. So, for a long time, the Canadian guidelines were the ones that were really pushing the Lp(a) message, saying, this really, if you have elevations in Lp(a), which is a version of an LDL particle that brings extra risk. About 20% of the population has elevations. If you happen to be one of those people, it does increase risk over time. And the higher your amount, the greater that risk. This recent guideline now advocates for universal screening, which means every adult over the age of 40 in particular should be tested for Lp(a) once in a lifetime, regardless of established risk. They could be low risk, they should still be tested because it changes our understanding of their risk. So Lp(a) as I'm going to say new, but that's not true. It's not that new, but interesting risk enhancer. Again, part of this whole package of risk enhancer pieces where we take that information, we ask those questions, firstly, of the people we're seeing. We take those, we understand, is there more than one? How significant are these things? Some people with gestational diabetes become dysglycemic and stay dysglycemic afterwards, even if they're not quite diabetic yet. That might differ than someone who's just has gestational diabetes and then has like normal blood sugar for a really long time by the time you see them. But it's still a risk enhancer, but you can see how it varies maybe in
Yeah.
our appreciation. And I think that's why we don't end up with if you see a risk enhancer, you have to do this. It's very much you need to ask about them. You need to understand if your patient has risk enhancers and to what degree. And then you need that, you need to let that inform the overall conversation. So you still go through the risk calculators it's written. You see where they fall in the low, borderline, intermediate, high risk categories. Then you look at what their LDL cholesterol is. You sort of follow the algorithm. And there's lots of great algorithms to kind of say, this is where we're worried and this is the step we take. But along that sort of determination is, are there risk enhancers? How many? To what degree? And then that moves us in the direction of being more enthusiastic about treatment. So again, it doesn't give a definitive, like if you see this, you have to consider this, but just bringing awareness to how important these pieces are, even if we don't have the concrete, like, oh, it increases your risk by Y amount. It's the value of knowing that it's an issue and then bringing that to the table.
Yeah. Yeah, and so I think these are all of, like, the really strong points, and I think just as we've been talking, as we start to close, like, the thing that I reflect on is that, like, this is opening up a conversation, I would argue multiple conversations around this prevention piece, right? Like, I think maybe what's sticking out to me the most is that especially I think cholesterol can just feel like this quick scream, like, you do it once, it's either high or low, and then you sort of, like, set it aside and never think about it again, or you're on a medication and you don't think about it, but that it's actually a very multi-layered conversation. I think we would argue there's like earlier is better, right? Like to start thinking about it early and that there are so many layers to it and that it also encompasses your own risk tolerance, right? Like I think we're talking about a lot of worst case scenarios. And so sometimes that might be okay for some people. People might want to be super preventative and want all that information, but that like having information to have conversations so we can start to decide what we want to do is maybe like reading in between the lines, but I think that is a really important part of the guideline, right? Like we're talking about risk tolerance, what people have control over, what you don't have control over, what we need to keep in mind. And this isn't one visit. This is multiple conversations and building an understanding of cardiovascular health, which I think is like excellent medicine. I know, Alex, you have been such an advocate for this type of relationship with these risk factors that to me in like a touchy-feely way, I feel like that's the thing that's jumping out at me at the guidelines of like just a different way of talking about these things, that it's not one and done. Like
Yeah.
there are
Yeah.
multiple conversations and that we start to understand, and that as a patient, this is all things that like you should be talking about with your practitioner. And like this is really the core of what it might look like. Hopefully
Yeah.
that's come through, I think.
I hope so too. And I think you're absolutely right. I think these guidelines, there's so much detail there. The guidelines are always overwhelmingly rich in information, right? So they're really not a novel that you read. It's like
So,
a tool that you go back to,
yes.
but they really do read as a guidebook to helping those discussions, this talk about patient-centered care and, patient goals and informed consent. It's not that doctors don't want to do that, but it's hard to fit it in
Mm,
time. And it's hard to know how to navigate those conversations when you don't have a lot of practical information to like present. And what I really love about these guidelines is I feel like it really provides tools and algorithms and pieces and resources that allow you to say, okay, like this is why. And like these were put together because we know that the cost benefit ratio of making this decision here is going to benefit you. Whereas here, even if your cholesterol looks like this or whatever, that cost benefit ratio is not as clear or it actually doesn't benefit you. And this isn't to come away with saying, okay, this is a guideline that tells you that everyone just needs to be on medication sooner. That's not the takeaway. At least in my practice, although I'm talking about medication all the time, I'm not a prescriber, but advocating and allowing people to understand when it is appropriate and why. What's really helpful from my perspective with the primary prevention piece is that we're looking at, wow, if this is getting on its way to being flagged, especially if it's in that like medication, it could go either way.
mm,
It's not the wrong choice. It's not the right choice. People love to know that, or at least most of the people that I'm seeing love to know that because they're like, oh, I can make some of these dietary changes or lifestyle changes that will influence cholesterol that maybe wouldn't be enough if I had to see a 60% reduction in my cholesterol.
yeah.
But if I'm moving in a certain direction and I can manipulate some of these things quite easily and sustainably, and it'll lead to a 15 or 20% reduction, which brings me safely into a zone that we're not talking like no one's worried.
Mhm.
Well, many people are very happy to have that information and would rather have that today than 5 years from now, where
Yeah.
different level of conversation. Yeah. So I think that's exactly right, that this is a framework for having great conversations with patients. And for a patient, allowing the physician to have a framework to answer your questions and to navigate sort of a more proactive preventive approach that they might not otherwise have had the blueprint for.
Yeah, totally. So I think on that note, it ends our discussion around the guidelines. Hopefully that was like a nice, fresh, like fresh off the press, but also
Mhm.
this like really useful tool that practitioners are referencing over and over again. And um, I hope it will prompt the cardiovascular health conversation as well at the end of the day.
Yeah, and we'll link to the document in the notes, maybe even a couple of sort of more lay resources that CardioSmart, which is part of these organizations, has put out just out of interest. It's a big document, but if you're interested, we'll make sure you've got it to look at.
Yeah, totally.
All right.
All right. We'll see you all soon.
Thanks, Antonella.
Bye.